So why don't you introduce yourself to the group and welcome. Oh, you're on mute.
I know.
Uh,
um, so, thank you for having me. My name is Tiffany Gallagher. I am uh, a, let me get my notes. 1 second. All right. Good
We can
evening.
see you. Sorry, Chipper, we can see your view.
Oh, interesting.
We can go ahead and
Oh,
introduce yourself while we figure that out. How's that? And give you a little bit more time.
sure.
All right, you got it? All right, go right ahead.
All right, 1 second.
yeah. I'll just say a few words about you while you're trying to figure out your
Yeah,
screen.
go ahead.
Um, so Tipper actually sent an email through APHA when they were looking for board members for the Breastfeeding Coalition. And I thought, oh, that's a really important and good topic to have a presentation on. So we chatted a little bit, and that's how she ended up here. She's a breastfeeding researcher currently using electronic health records to examine inequitable breastfeeding care during the postpartum hospital stay. She earned her doctorate in nursing and a graduate minor in public health from the University of Minnesota Twin Cities in May 2025 and is a President's Postdoctoral Fellow at the University of Minnesota School of Public Health. She's an international board certified lactation consultant since 2015 and spent about 6 years as a clinical lactation consultant with Hennepin Healthcare and in private practice. In addition to her research, she works part-time as the Interim Executive Director of the Minnesota Breastfeeding Coalition, and she lives in New Ulm with her partner and their blended family and 3 cats and 2 dogs. So, welcome.
Thank you. Oh, goodness. I'm never going to be able to figure this out, I don't think.
Do you have 2 screens? Is that what you're trying to?
I do have 2 screens.
You should be able to switch them if you need to. Or if you're sharing, you can go on and do share. It should tell you which screen to share.
Okay. Usually I'm not the person who has the technical difficulties, but it is what it is. So you guys seeing my slides
Yes,
and not my notes.
right.
Ooh, okay. Then
Oh,
we're good.
now your notes just showed up. Whatever you just did, just switched it back.
Okay.
There you go.
All right. Okay. So sorry about all that. So good evening. My name is Tiffany Gallagher, and I'm a postdoctoral research fellow at the University of Minnesota School of Public Health. As Erica mentioned, I'm a new PhD. I got my doctoral degree in May, and I have that is a doctoral degree in nursing with a minor in public health. So I am the Interim Executive Director of the Minnesota Breastfeeding Coalition, which I've been since March of 2025. I'm also an international board certified lactation consultant, and I was doing clinical lactation care at Hennepin Healthcare from about 2015 when I got my IBCLC to 2020 when I switched over to doing breastfeeding research. So for disclosures, I have no commercial conflict of interest, but I do want to disclose that my research fellowship is paid by the University of Minnesota, and I also get an hourly salary as the Interim Executive Director of MBC. So tonight I'm going to provide some hot off the press statistics from the Minnesota Department of Health compiled by state epidemiologist Marcia McCoy about breastfeeding rates in Minnesota, as well as how we're measuring up against the rest of the United States when it comes to hospital practices that support infant feeding. I'll also share some findings from my own research and some findings from a recent study about the lactation workforce in Minnesota. And then I'm going to introduce you to the Minnesota Breastfeeding Coalition, our mission and purpose, and some projects we've been working on related to infant feeding equity. I like to start every presentation about breastfeeding with the basics, and that is that breastfeeding and providing breast milk is important to infants' health, nutrition, and development. And increasing breastfeeding rates has been a cornerstone of maternal child health recommendations for decades. Breastfeeding is associated with a lower risk of maternal high blood pressure, type 2 diabetes, and breast and ovarian cancers, and lower risk of child obesity, type 1 diabetes, respiratory disease, ear infection, SIDS, and gastrointestinal disease, including nephritizing and enterocolitis. For these and other reasons, the CDC and other major medical organizations advocate and recommend exclusive breastfeeding for at least the first 6 months of life and continuing to breastfeed for at least the first year. And this goal we greatly fall short of in the United States. So we generally see an upward trend in breastfeeding rates over the years, but disparities persist. Black non-Hispanic infants are the least likely to be breastfed, the least likely to exclusively breastfeed through 6 months, and to be breastfed at all at 12 months. Whether formula is given during the hospital stay is the greatest predictor of breastfeeding duration, and yet nearly 20% of infants are given formula within the first 2 days of life. Supplementation rates are higher in Hispanic, Black, and Asian infants compared to non-Hispanic white infants. And this is despite over 80% of parents intending to breastfeed, and there's no difference in this intent by race or ethnicity. There are also notable disparities in breastfeeding rates by other social determinants of health, including age, weight, rurality, spoken language, and education level. Compared to national rates of breastfeeding initiation, Minnesota families are doing better than average. You'll notice, though, that we still have obvious disparities by race and ethnicity. That Black and African American, non-Hispanic, Native American, and non-Hispanic Hmong families have breastfeeding initiation rates far below the average. And I'd like to point out how varied the rates are between different racial and ethnic subgroups, which illustrates how it's worthwhile to take cultural background into consideration when looking at breastfeeding rates as well. In looking specifically at WIC participants, you'll notice that their breastfeeding initiation rate is lower than the state and the national average, but there have also been notable gains over the past 5 years, especially in the number of families breastfeeding at 3 months. Minnesota WIC's emphasis on breastfeeding promotion and education is excellent, and efforts are paying off. But if we look at breastfeeding rates, initiation rates among WIC participants, they are generally lower than average as well, and quite low in general. And that is really typical for WIC participants. However, the goal is 85.8%, and we're at about 47% in 2024. So every 2 years, the CDC sends a voluntary survey called Maternity Practices in Infant Nutrition and Care Survey to every eligible hospital in the United States. The survey asks questions that gauge how supportive hospitals are of breastfeeding. Hospitals can collect this data to answer these questions using any method they choose, and their answers do not need to be highly specific. Overall, hospitals with higher MPINC scores tend to have better breastfeeding outcomes. In 2024, about 81% of eligible hospitals in Minnesota participated, and the state score was 81, which is 1 point below the national average. And you can see an example question at the bottom of the screen. So while the methodology changed slightly a couple of years ago, and we're not supposed to directly compare scores from then and now, Minnesota's MPINC score ranking compared to other states is currently lower than ever, although there was a brief uptick in 2015. At that point, Minnesota had its highest number of baby-friendly hospitals. Currently, there are only 6 hospitals in the entire state that are designated as baby-friendly. Hennepin Healthcare is the only metro area hospital that is baby-friendly. The others are Essentia hospitals in Brainerd, Virginia, and Duluth, St. Luke's and Duluth, and Perham Health and Perham. So Minnesota's MPINC score did not change between 2022 and 2024, but with the exception of North Dakota, which did extremely poorly, the surrounding states have improved their scores during that period, which I think should make us feel a little competitive. It is particularly interesting, in my opinion, to compare our MPINC scores with that of, for example, Mississippi, which is at 87, 6 whole points higher. And Mississippi has some of the worst maternal health outcomes and lowest breastfeeding rates in the United States. However, they have put a lot of effort into improving breastfeeding support there since 2014. At this point, 90% of their hospitals are designated as baby-friendly, and breastfeeding initiation rates in Mississippi have gone from 42% to 63% since 2014. So they put in the work and they're getting the results. So this year, the Minnesota Department of Health undertook a survey of lactation providers throughout Minnesota to gauge the level of support people are receiving in and out of the hospital. They did their best to capture information from every practicing lactation supporter in the state. As you can see from this map, the vast majority of lactation support providers are concentrated in the metro area and in St. Louis County. And 11 counties had no lactation support providers reporting at all. Over half of the individuals surveyed are from nonprofit or community organizations, and only 13% of those surveyed are employed by a hospital, clinic, or health system. Clearly, we do not have a lot of lactation support providers in Minnesota. So in order to get breastfeeding off to the best start possible, it is critically important to provide individual support and education to parents and infants through this vulnerable period of establishing lactation that occurs during the postpartum hospital stay. And the American Academy of Pediatrics recommends that a health professional trained in formal assessment of breastfeeding perform and document an assessment at least once every 8 to 12 hours during an infant's hospital stay. This is roughly once per nursing shift. Nurses are usually the ones providing this care. And as we saw on the previous slide, most people providing lactation support in Minnesota are not working in hospitals. So deciding to breastfeed and having the resources to be successful all occurs within a layered system. Not only are your individual factors a consideration, but the relationships you have, including what support you receive from family and care providers, the resources of the community you live in, and societal opinions and structure all play a role. One of the challenges of breastfeeding research is trying to understand why some people find more success with breastfeeding than others. Are there fundamental differences between people, or are there other factors involved? The one thing I was interested in finding out doing my dissertation was whether the disparities we see in breastfeeding rates are a reflection of individual preferences or limitations, or if the care they're receiving may be different. Like most things, it's probably a complex interplay of various factors. But like in other disciplines, there's literature in lactation and nursing care that points to care provider bias being a potential factor. So the data I used in my dissertation work, and I'm still continuing to work on, was obtained through the Clinical Data Repository, which collects data from 9 hospitals operated by Fairview throughout urban and rural Minnesota. In this study, I included births between January 1st, 2018 to December 31st, 2022. I included infants born at 37 weeks gestation and later, whose parents opted into research. The inclusion and exclusion criteria were meant to create a cohort of healthy birthing parents and their full-term dyads. So these are mother-infant pairs who would be the least likely to need anything other than regular nursing care. This process was submitted to the IRB of the U of M and met the criteria for an exemption for a full IRB review. So without getting into too much detail, although if you want all the detail, I will have a methods paper coming out soon, hopefully. I used health records to come up with 2 outcome measures. I looked at breastfeeding intensity, which is basically the percentage of feedings that were breast milk, and a support ratio, which was simply put the number of times there was documented breastfeeding support divided by the number of times a person should have had documented breastfeeding support. So as mentioned earlier, the recommendation is that everyone receive documented breastfeeding support at least once per shift. So in 24 hours, there should be 3 entries about breastfeeding support for each baby. If the baby is in the hospital for 24 hours, and has 3 entries, that baby received the recommended amount of support, and that is a support ratio of 1. So looking at the overall demographics of the sample, this gives us an idea of how the hospital system measures up to Minnesota and the U.S. as a whole. While the breastfeeding initiation rate is higher than the state and national average, over 25% of infants who began breastfeeding during this period received formula within the first 2 days of life, which is higher than the state and the national average. So in looking at this data set, based on research and clinical experience, we identified demographic and clinical factors that may be relevant to breastfeeding success or the care someone receives. So, for example, needing an interpreter can be a barrier to receiving health care, and babies born at 37 to 38 weeks gestation are more likely to need supplemental feeding. And these factors were all used to adjust our statistical models. Don't worry, I'm not going to get too crazy with the statistics. So there were statistically significant differences between all feeding methods for every demographic and clinical factor examined, except for parity, that is the number of babies that have been born to someone. So looking more specifically at differences by race and ethnicity, we can see that white non-Hispanic patients have the overall highest exclusive breastfeeding rate and the highest support ratio of anyone. That means they had more documented breastfeeding care. Every other group by race and ethnicity have lower than average exclusive breastfeeding rates and a lower than average support ratio. Black non-Hispanic patients have the lowest exclusive breastfeeding rate, less than half of the rate for white non-Hispanic patients, and the lowest support ratio of any group. So they receive the least amount of breastfeeding care. So the most important takeaway for you guys today about my research is that lactating patients were less likely to have the minimum recommended amount of support documented for a very wide variety of reasons. For example, if their feeding intention was to provide both breast milk and formula, they have less support documented. Likewise, if their race and ethnicity was not Hispanic, and they were African, American Indian, or Alaska Native, Asian, Black, or African American, or did not have their race documented, they did not have as much support documented. if they needed an interpreter, were under 25 years old, were not married, had public insurance or no documented insurance, had a higher BMI, were current smokers, had a cesarean birth, a baby born early term, so 37 to 38 weeks, or had a low birth weight baby. All of these people were at a higher risk of having less than the recommended breastfeeding support documented. So, and basically, these are all of the categories that we as breastfeeding supporters and lactation consultants look at as being at the highest risk of not initiating breastfeeding and not continuing to breastfeed. So, and that is really interesting to me, given my hypothesis that that some of these disparities that we have to do with the amount of care people are given. So it remains to be seen whether there's a direct relationship between some of these things. Like if there is a lot of bias happening, it's probably some combination of bias and other causes. But certainly it's evident from what I've been looking at that at least in this health system, people are not getting the same amount of support. And that is absolutely crucial. I'd like to point out that, some people might say, well, of course, if someone doesn't intend to exclusively breastfeed, of course they wouldn't get as much breastfeeding support. But importantly, a lot of people do want to breastfeed exclusively until a certain amount of time. And they often do not get asked questions about how long they intend to breastfeed or when they would like to switch to formula. So anyone who is breastfeeding in the first 2 days of their baby's life needs to get as much support as possible in order to establish their milk supply. So even if someone intends to use some formula, they still should be getting the same amount of breastfeeding support as anyone else. So what can we do about it? For my part, I am going to keep researching and keep looking for ways to improve hospital support and make it more equitable. And I'd also like to tell you a bit about the Minnesota Breastfeeding Coalition, which is an organization working to support, promote, and protect breastfeeding throughout Minnesota. And we've tried to do that in many different ways over the years. So a little background about MBC. MBC was formed in January 2006, which means next year we will turn 20 years old. And it happened after the first National Conference of State Breastfeeding Coalitions. In 2009, they became a 501c3 nonprofit. Currently, we have as members 22 local and cultural coalitions. So all around the state, we have local and regional and cultural coalitions, including the Indigenous Breastfeeding Coalition and the Hmong Breastfeeding Coalition. And they just gather together people in their area and work on projects related to breastfeeding support and promotion and advocacy in their area. A lot of the breastfeeding coalitions right now are headed up by public health departments, and a lot of SHIP personnel or WIC offices are heading up those breastfeeding coalitions. And there used to be a lot more, but especially when COVID happened, a lot of them kind of disappeared. And I think part of it has to do with just general burnout in the healthcare and public health community, and people just do not have the capacity to do this kind of volunteer work anymore. But our members include individuals from state and local health departments, from WIC, from hospitals, the Leslie League, and other organizations, and individuals that support and promote breastfeeding. Anyone can become a member. You do not have to be anyone related to breastfeeding to be a supporter of our cause. And our memberships are very inexpensive, $25 a year. And there are some perks that go along with that. Please visit our website if you want to know more. So our mission and vision are as follows. So the vision is breastfeeding healthy babies, healthy families, and healthy communities. And our mission is to work collaboratively to create environments where breastfeeding is valued and supported, and to achieve natural infant feeding equity in all Minnesota communities. The purpose of MBC is several-fold. A large part of what we do is raising awareness and educating healthcare providers, public health workers, and the public about the importance of breastfeeding. We collaborate with a number of agencies and other nonprofits, such as the Minnesota Milk Bank for Babies, which is our Minnesota's human milk bank. We produce webinars and conferences and work on special projects. Our people drive our focus, and since this organization is mostly run by volunteers, the projects we tackle vary from year to year. These various projects have included working with child care providers to inform them of how breastfed babies may have different feeding needs than babies fed formula, and working with employers to provide comfortable lactation spaces in accordance with Minnesota law. We've also published prenatal breastfeeding guides, so people like midwives, physicians, and educators can easily cover information about breastfeeding before babies arrive. Tonight, I'm going to highlight two projects that are very much geared toward improving infant feeding equity. So in 2023, MBC partnered with Children's Minnesota, the Minnesota Milk Bank for Babies, Health Fairview, Brighter Health, and Muslim scholars and religious leaders to create the very first U.S. fatwa that supported the use of pasteurized human milk for Muslim babies. It might be the first one of its kind in the world. It's very, very cool, in my opinion. So typically, Muslim families have either refused or not been offered donor milk for their infants at all, because there's a concern about something called milk kinship. And that is the idea that babies who consume milk of one mother become siblings. So the problem with donor milk is that you don't know who the milk comes from. So if your child may accidentally be milk siblings with someone they're not aware of, and if they were to, for example, be in a relationship with them later, that would be problematic. But so this means that a lot of people have just not even have the opportunity to use pasteurized donor human milk for their fragile babies, or they refuse because of religious reasons. So this whole initiative was prompted by people in the Muslim community who were concerned about this disparity. And these people came together to work on creating this guidance that clears up the teachings about this issue and encourages families to choose pasteurized donor human milk for their infants if their own mother's milk is not available. So it is quite a neat thing, I think. And Marcia McCoy, who's in the red dress in this picture, and who is the epidemiologist who gave me lots of these statistics, is doing a lot of research around the fatwa and donor human milk for Muslim families, and all that sort of stuff. It's great. So another project that we're all very excited about at MBC and is ongoing is called Next Gen Lactation. So we started Next Gen Lactation in response to coalitions and communities having concerns about how difficult it is to access the education and clinical internships required to become an IBCLC. So becoming an IBCLC is often a years-long process, and it involves taking 14 college-level health science courses, completing a 95-hour lactation-specific course, and doing between 300 and 1,000 hours of clinical hands-on support, and that is almost always unpaid. Then you also must pass this rigorous and difficult and terribly written international board exam. And just finding a place to do clinical hours is an enormous barrier to many people. There are only a few places that have interns. I know of only three hospitals in the Twin Cities that have interns. A lot of people have to cobble together hours from various different places. I personally got all of my internship hours done at Hennepin Healthcare, and it was very, very difficult to get that clinical internship simply because there's only 2 spots available. You only get do onboarding once a year. It's hard to get in contact with people who run the program. There's just many, many barriers there. So especially for people who don't have privilege, and especially a lot of people do not have time or money or the opportunity to be able to do an unpaid internship that is months and months of work. So NextGen finds folks from communities that are traditionally underrepresented in the lactation profession and provides financial support and mentorship as they work their way through the requirements to become an IBCLC. I should share too, like the expense of becoming an IBCLC is significant. Time is like the biggest expense, but taking college courses costs money unless you have the resources to figure out where to take courses that will meet the requirements for free or low cost. There's also the training is not cheap. It costs about $1,000 for the 95-hour lactation training course. It costs almost $700 to take the board exam. And it's just a whole lot of time, a lot of time. Financially, we assist people, and we also provide mentorship. Another important statistic, I suppose, is that in Minnesota, like less than 1% of our lactation consultants are people of color. And NextGen has increased that number by several fold. So our first candidates, as we call them, started in 2021. So we're 4 years into the program. In 2024, we had 3 ready to take the IBCLC exam, and all of them passed, and all of them found employment as lactation consultants. So that is amazing. We have about 10 individuals in the program at a time, and they're all at different stages of their journey. We've helped them figure out what courses they need, helped to pay for childcare. We have helped when internship sites put up unnecessary barriers, such as requiring 8-hour days instead of something more flexible. We organize study groups. We troubleshoot, like, what can we do with a person whose first language is not English and she's having difficulty with the exam materials, or can we advocate for these people to take the exam in their native language rather than English, even though they're in the United States, that sort of thing. And all of this happens under the guidance of the NextGen subcommittee of MBC, and we also have a NextGen coordinator who is a graduate of the program herself. In this picture, she is 3 people in from the last. Her name is Zabby. She's incredible. So this picture is a little gathering that some of our NextGen candidates had with Barb King is on the last few. Some of you might recognize her. She used to work for the Minnesota Department of Health and the WIC program, and she's the chairperson of the subcommittee. So that is all I have for tonight. I would love to answer questions and provide more detail. I know I kind of zipped through a lot of this stuff, and there's so much to unpack when it comes to this topic, and all of the things that go into our inequitable care and why certain groups breastfeed more than others. So I'm happy to answer questions and also listen to your stories if you have them, and you are more than welcome to reach out to me if you would like to. Thank you.
So thank you for the presentation, and we'll stop the recording now. And that's to allow for more different discussions. So Sunava, if you could stop the recording, that would be great. And we'll just wait a minute.